So treatments for osteoarthritis of the knee. Now, what I have on the screen currently are things that are typically done by the individual first as they start to notice some pain in the joint. Increased exercise can sometimes help with this thing. Walking, particularly swimming. These are exercises that still provide the benefits of exercise but don't provide as much pressure on the joint as, say, running or jogging. By taking some of the pressure off the joint and still allowing us to get the benefits of exercise, a lot of times we can see some decreased pain from an early arthritis. Certainly weight control aids in taking some of that pressure off. You're not putting so much pressure on a joint. And medications like NSAIDs or hopefully not painkillers, but these are things that can help with the pain that you can take, well, at least NSAIDs over the counter. Now, when it gets to the point that you want to engage a medical professional, then they're going to start coming at you with a couple of different things. So the current medical algorithm is typically this. First, you're going to go into your orthopedist or your family doc and say, hey, my knee's hurt, it's been doing this for a bit and I want to do something about it. Well, typically they'll say, all right, this is early on, we haven't seen much yet, maybe we'll consider some physical therapy, but usually the first thing that they're going to do is say, well, we'll put a little bit of steroid in the joint, just give you an injection, see if that helps. Then, like I said, typically on to some general physical therapy, let somebody kind of work you over a little bit and see if that doesn't take away some of the pain. Then, after steroids and physical therapy, if those haven't really done the trick for you, then they might say, well, okay, last ditch effort, let's try some viscosupplementation, or what sometimes referred to as the gel or rooster juice. See if that helps. If it doesn't, then we go on and we recommend surgery. Or surgery is recommended to you. Now, so this is kind of the basic algorithm that is put together for most students and residents. However, in practice, this is usually what we see is that steroids are tried and they're tried and they're tried and they're tried, and physical therapy, while maybe sometimes used, is typically not looked at very highly and typically tends to kind of fall out of the algorithm. At least it's not super encouraged. And it tends to just be a generalized physical therapy anyways. The doctor just says, well, go see somebody and then come back when you're done. There's not any real specialty involved there. Then further, viscosupplementation. Since about 2013, a lot of insurers, particularly in the state of Kentucky, require that you try viscosupplementation before surgery. So typically, I don't hear this getting called on a lot until basically the steroids, if they ever worked, have stopped working, and now the joint is pretty much shot. So they try to throw some gel at it to do a one-time shot. Either it helps or it doesn't. If it does, great. If it doesn't, then we just go into surgery. But it's not uncommon at all that I hear patients come in and they say, well, I went into my doctor, he tried steroids for a while, it didn't work, and so now he's recommending surgery. And viscosupplementation is kind of jumped over altogether. Well, and so then the other option of painkillers for knee osteoarthritis obviously doesn't do anything to help the joint, it just masks the pain, and so I'm not really going to talk about that, particularly in the state of Kentucky. We've got all kinds of issues with painkillers, and so I don't even regard this as an appropriate treatment. Cortisone injections. So these are the steroid injections. Just to dig into that a little bit more, what a cortisone injection is when we're talking about steroids, it is a powerful, powerful anti-inflammatory, similar to what we use inside our body, just a much, much higher dose than your body would normally use to try to control the swelling itself or the inflammation itself. It is a balm that just eliminates all inflammation in the area for most people. So this can provide pretty good pain relief. However, inflammation is not necessarily the bad guy here. The bad guy here is the wear and tear. Inflammation is just a symptom of that. So when you do something that gets rid of the inflammation, really all you're doing is covering up. Now it does have side effects. Steroids are a medication that chemically changes the composition inside some of your cells. It has an effect on the bone, osteoporosis. There have been studies showing that it can lead up to about an 8% loss of bone in 4 months. This is one of the main reasons that your doctor cannot give you steroids for more than one shot about every 3 months, 6 months for some docs, but for most docs it's 3, because the guidelines are that you do not give 4 of these shots, any more than 4 shots of steroid in one area of the body, or more than 4 in a year's time. So that's why it gets split up into about at once every 3 months. Low doses for a year can cause cataracts. That's more of a continual steroid thing. A single shot will almost inevitably elevate your blood sugar. For most of us, that's not a big deal. It just causes a bit of jittery sensation. I had one patient that got a steroid shot and woke up about 4 days later in the middle of the night, wanted to clean their house, but they felt great. So that wasn't a big deal, but it can cause issues. This is an issue for diabetics. Suppresses your immune system. That is what a steroid is. When it's knocking down inflammation, inflammation is part of the immune system getting to work, and steroids just wipe that out and cut off all the chemical signals for your body that it's trying to heal itself. So that's the main issue that I have with steroids and cortisone injections, is that it speeds the breakdown of the joint in 2 ways. One, just it eliminates all the inflammation, and it slows the ability of the joint to turn over good and get new good tissue. So the tissues start to get brittle, particularly with repeat injections. When somebody's going in and they say, well, you know, I've been getting shots in my knees for the past 2 or 3 years. Well, that has just been wearing on that tissue inside the joint and making it more and more brittle. What it's also doing is it is eliminating the inflammation and the pain, but not the wear and tear that's causing the actual problem. And so the person goes, hey, I feel great, and goes out and walks on their joint and continues to beat it up, and it probably breaking down even faster. So they can provide some short-term relief because it is a very strong anti-inflammatory, but ultimately leads to long-term destruction of the joint. So I guess the bottom line is, if you're just starting to have some knee pain, you may take 1 or 2 to try, but if that doesn't provide significant long-term relief, like years of relief, then you're best to just leave them alone, because you're ultimately going to do more damage than you are good with them. Okay, so that was number 1. Number 2 is the surgery. So what's wrong with knee replacement surgery? Now I want to start off by saying that I am not trying to bash surgery. Surgery is an awesome tool that we have when the joint is at the end of its life. However, I'm going to make an argument that it is overused, and we assume the joint is at the end of its life much sooner than it actually is. So the reason why we don't want to jump to that conclusion too fast is that surgery inherently has some issues with it. First off, one size just does not fit all. There are way too many of these done. Well, saying we're seeing a 600% increase in knee revisions in the next 10 years, but I mean, really, we're just seeing such a vast increase in the number of these surgeries being done. And as they are getting better, and the surgeries are getting better, that tends to just mean they're being done more. They don't last. Now, your doctor will tell you this. or the surgeon will tell you this, they're typically rated for about 15 to 20 years. And I do know people that are currently in their 25th year on their joints, on their replacements, and still doing just fine. So they can go for a good long time, but most of them are going to wear out in about 15 to 20 years. 10%, about 1 out of 10, fails within 3 years and needs to be redone within about 3 years. Painful recovery, this is usually one of the big reasons that people come in to see me and say they don't want surgery. It's not because they have any concern about the surgery, but they just don't want to have to go through the rehab. Now, this states that most recoveries take about 12 months before you're really fully back to doing the things that you want to do. Now, this is getting better. The surgeries people are getting out of the hospital sooner. These are almost coming to the point where they're being outpatient procedures. They're getting people up walking the same day or the next day, and leading to much better recoveries. And we're getting much better with this, but it's still, again, most people come into me because either they've had one joint replaced and don't want to go through the recovery again, or they've seen loved ones or friends that have gone through that process and just said, they don't have enough time to slow down their life for 6 to 12 months while they're recovering. Anesthesia is a problem. I won't necessarily go into that a whole lot, but particularly in the elderly, this causes issues with delirium and dementia that you should certainly talk to your surgeon or anesthesiologist about those risks. I'm not going to necessarily get into that more here. What I want to kind of talk about is a little bit about disappointing results. So this was a slide that was given to me about just kind of eyeballing some of the outcomes patients had, where it says about a quarter of people did great, pain's completely gone. A quarter of them, pain was better, but still kind of there. Again, all those people, about half of everyone is glad they had their knee replaced, but it's also saying about half of people are not necessarily happy with their replacement. Either the pain is same for a quarter of the people, or for 25% of the people it's worse. When I first saw this, I thought this was a little bit overblown, because typically surgeries do really well, and we get information back that says about 90% of them are successful, and that would be very contradicting to what we had here. But the more I looked into it, I'm actually thinking that this slide is probably not as far off as I initially thought it would, and I'll go into that in a second. So first, real quick, I'm going to talk about the unsuccessful surgeries. So this is that 1 out of 10, that 10% that's not considered to be successful. About 4% of all the surgeries done need to be revised in about a month and a half. 10% need to be revised in about 3 years. Again, that's the 1 in 10 that are unsuccessful. These are the type of complications that we see with it. Most commonly, there's a mechanical complication of the prosthesis of the new joint that's put in there. Either it slips or something happens mechanically with the joint. Sometimes, these are pieces of machinery that are created by man, and sometimes they just fail and don't work as well as they should. Sometimes that type of thing happens. From the surgery, these are pretty invasive surgeries, so you can see things like blood clots causing DVTs, pulmonary embolisms, this type of thing. Typically also causing cardiac complications or just inherent complications that come with the trauma of the surgery. Postoperative infections, these are the really bad things that you don't want to see that happen immediately after surgery. Just those ORs are very clean, but these things happen, and unfortunately you do see death in a small percentage of the time. So what I'm more interested about is the successful surgeries. So about 90% are rated as successful. So 9 out of 10 people are happy with what they're doing. However, you start to get some of these studies when, in this one they're talking about function. It was a study from the National Institute of Health where they looked at 24 out of 24 total joint replacements where the afterwards their functional tests, they performed worse. All 24 performed worse than healthy adults. Well, that's not too surprising, but most of them at 6 months had returned to their pre-surgical levels of functioning. Now, pain was typically better in these people, but their functional level was basically about the same where it was after 6 months of the surgery. Their functional level was about the same place that it was before surgery. Now, these are some things that you have to worry about. Again, this is a successful surgery. You have to worry about delayed or late infection, bacteria from other areas of the body that come in and they adhere to the prosthesis and can start to grow. They grow a biofilm in there and lead to infection. So that is why anybody who's had a joint replacement, if you're getting anything done like even as simple as a dental cleaning, they're worried about little minor cuts in your mouth, getting some of the bacteria from your mouth into your bloodstream and then going and causing a significant infection in your prosthetic. So you typically have to have antibiotics, even for something as simple as a dental procedure. Arthrofibrosis, this is excessive scar tissue that can grow within the joint. Again, this is typically still referred to as a successful surgery, but this a lot of times is something that has to be dealt with because it's either causing limited motion within the joint that needs to be worked out through kind of a more invasive physical therapy, or sometimes even a surgical procedure where they have to go in and clear some of this up. So this is a lot of what I see here are the musculoskeletal issues that come about after surgery, usually because somebody's the way they move is slightly different. So this leads to a new onset or an increase in their low back pain, ligament instability. There is a documented increased risk of fractures to the hips and the spine following knee replacement. And unfortunately, we also see a chronic joint pain in the joint that was replaced after some of these procedures. Now, this is a study that was done. Basically, what it was looking at was a qualitative study. It was basically investigating what we know as the 90% of people with successful surgeries. This was in rheumatology in 2005. And basically, it was looking into the idea that 90% of these surgeries are rated as successful. However, we see anecdotally, we see a lot of people who continue to have issues after the surgery to what would seem to be a larger degree than only 10% of those that aren't failing. So this study basically took 10 people, talked to them, surveyed them before the surgery, and then 6 months after the surgery, talked to them again, gave them a survey, but then sat down and actually really kind of dug into it a little bit. So 9 out of 10 of these people reported excellent, very good, or good, so successful surgeries, which is pretty much exactly what is reported in the literature, 90% success rate. So only 1 out of the 10 subjects reported that they were that they had an issue with the surgery and would consider it themselves to be unsuccessful. But once they went and started talking to people a little bit more, they found some interesting responses. For instance, Miss D, 64-year-old female, initially said that she had a very good outcome, very happy with the results, very worthwhile doing. However, once they kind of talked to her a little bit more about it, she said, well, I do get a lot of pain in both knees. I can't do certain things that I want to do. shopping, going up and down stairs, very painful actually getting on the knees. And so she indicates that even though she did consider it to be very good, she actually does have quite a bit of pain still involved with the knees, despite having entirely new knee joints. Miss L, she admitted to being in as much pain after the operation as before it. However, since she was under the impression that the bad, quote-unquote bad arthritis had been removed, that the knee must have been better even though she was still having the same amount of pain. Mr. P, 48-year-old male, again, similarly thinking that it can't be the actual joint since there's no joint there. Therefore, it must have been his fault. The surgery was done well, but just the fact that he's having pain must have been something he did. Mr. O, still restricted, but grateful for all the attention that he got, and still considered it to be pretty good because he was treated real well. Miss S, still experiencing pain and immobility after 6 months. Now he believed this was God's way of trying to improve him as a person. Again, all of these people are people that considered the surgery a success. Miss B, getting pain down the back of her legs. Now that may not have been necessarily related to continuing knee pain, but increased back pain. Again, says she should have rested it more. I was told I'm more or less too impatient. Again, somebody that's still having issues. Told that it was their fault. Still a successful surgery. Can't walk up and down the steps normally. Yeah, and says, she's pushing it and pushing it. Still considered successful surgery because she doesn't want any more. So of the 10 people that had it done, only one of them reported it to be an unsuccessful surgery. However, once they kind of dug into it a little bit more, 8 out of the 10 people reported continuing to have significant pain or limited function. So in 2013, 750,000 knee replacements were done, and here you can see a picture just showing a little bit of how brutal that type of surgery is. Here's some x-rays following. This is a partial knee replacement, which is getting more popular. Now, when I went through my training, this was really not something that we saw very often because it just didn't work very well. They didn't last very long, and typically it was only a stopgap. For the people that did get it, typically within about 5 or 7 years, they had to go back in and do a surgery to get just a full thing done. And so that, having 2 surgeries, most people just said, well, you might as well get the whole thing done and get 20 years out of it. But these are getting better. Again, recovery times are improving. The surgeries themselves, now they got robots that are basically doing this without any surgeon intervening at all. Robot does the measuring and cuts and does everything after a surgeon lines it up, and so these are getting much better. And here's the full replacement. You can see how basically cuts made here. This is cemented on and put on with the pressure that we saw in the picture before of the knee that was open, and this piece drilled out and a spike put down into the lower part of the leg, and this is the new joint.